Hi, this is Amanda Brummitt. I'm here today with Dr. Kara Farley from Mid-Cities Direct Primary Care. Thanks for being here, Dr. Farley.
Absolutely, Amanda. Thanks for having me.
Sure thing. Well, let's start with how the DPC model allows you to practice medicine differently than a traditional insurance-based setting.
Absolutely. I think the biggest thing for our patients, whether they're employer group patients or just traditional retail patients in our practice, is the accessibility to care. They can call us, they can text us, they can send us a secure message, they can do video calls, they can come in and have an hour-long annual visit with us. And so that accessibility, especially weekends and after hours, really is big for our patients. I hear so many times that patients called the doctor, left messages, sent portal messages, and they went unanswered. And so I think that access is really great for our patients. And then I think the next biggest thing is the ability for me to spend time with my patients so that I can explain to them why we are choosing this treatment, and so that they can be a partner in their healthcare decision making. And they can really understand what their options are and why I would recommend a specific option for them.
Yeah, those all sound amazing and like they create great access and way better care. So, in addition to that easy access to you, what kind of services are typically included in their membership?
Yeah, so any and all appointments. So all messages, texts, virtual calls, all included. There's never an extra bill for those. All of our office visits as well. Our practice is probably a little unique, I would think. We are a pretty robust practice. So sutures, we do hormone replacement pellets, we do a lot of orthopedic care. We also do a ton of biopsies, skin treatments, all of those sorts of things. And that's never an extra cost for anything that's done in our office. Cryotherapy as well, warts frozen off,
Oh, nice.
all of that.
Fabulous. And I know most DPC practices offer all of that. Do you think with your military background that you're even more comfortable providing that full scope of primary care?
Absolutely. And I think that goes back to the type of training that I had. I was really trained to be the only physician available.
Mm.
Um, I was trained to practice with the idea that I didn't have the luxury of referrals. So being able to manage broken bones and basic orthopedic injuries to more complicated disease processes, I think that that training really definitely helps our practice be very robust.
Awesome. And then when you're working with employers, how do you support the health and productivity of their teams?
So, our employer group patients get the same access to care.
Mhm.
That is probably the biggest benefit from the employer's standpoint. The employee really likes it, but for the employers, that really saves them on cost on the utilization of their health insurance. So, for example, on a Saturday morning, they wake up and their kid has had pink eye all week. Now they have pink eye.
Mm.
In a typical practice, they're not going to be open on Saturday, and so they're going to have to go to an urgent care, and that's going to cost between $1,500 and $2,000 for them to be seen at an urgent care for that urgent level of visit, and that is going to get billed through the insurance. Now, they personally may only pay $100 or $150 for their copay, which again is a lot for some eye drops.
Yeah. Mhm.
But that is going to be that 1,500 to 2,000 is going to be billed through the insurance. So the next go around when they reapply, that employer is going to have all of those hits and utilizations, and that is going to drive up the cost of the insurance for the employer and the employee. So that is really where the biggest cost savings is, for the employee and the employer.
Yeah. And that's huge, huge. What about results with your DPC patients on their health, like with managing chronic conditions or reducing ER visits?
Yeah, our patients typically do not go to urgent care. They very rarely go to the ER unless I feel like we are needing an admission. Truly, if they're having
Hmm.
a heart attack or if they were in a severe car accident, they need emergency surgery. those are the reasons to go to the ER. Those just kind of traditional ER visits for, cough, cold, flu, those sorts of things. Those are all usually avoided in our style of practice, which is great for our patients. But as far as the outcomes on chronic condition management, I think that is the biggest perk with DPC. And that goes back to being able to explain to the patients why they are getting a certain treatment for their disease process. So, for example, in a traditional practice, and I think most of us have experienced this, we go in for a toenail fungus, let's say. It's been there for, 8 months, and it took you 2 months to get in for the visit. So here you are. And the doctor walks in and they say, hey, yep, look at your toe. You got a toenail fungus. I'm going to give you this little liquid. You're going to paint the toenail polish on your toenail. It should go away. I put in the script already. And also, by the way, your blood pressure's high. It's 156/96. So I'm going to give you blood pressure medicine. You just take that every day. Okay, have a great day. Do you have any questions? Bye. And they close the door before you can even ask anything else. And that occurs because they have to have 15-minute appointments so they can see 25 to 30 patients a day to be able to actually run a practice, because the insurance reimbursements are so low for primary care.
Mm.
So that is what has caused that 15-minute appointment. So now the patient, one, does not understand why they have high blood pressure or what even the definition is and how bad their high blood pressure is. They don't know that this medication is now chronic and they're going to have to take it for the rest of their lives. They also don't know anything that they can do from a lifestyle standpoint to try and fix their high blood pressure. So that patient is now going to leave with a much less chance of being compliant on their treatment process, and maybe not even with the right treatment process, because maybe they just needed to discuss diet and lifestyle and be encouraged and given a handout on healthy eating habits. And if they lose 20 pounds, if you lose 5 to 10% of your body weight, that chronic disease process usually resolves. But nobody sat down to tell them that. And the other thing is, nobody told them that they had to paint their toenail for 48 weeks every day. And so now they're going to paint it for 4 weeks and then throw the bottle away. And then their toenail fungus is going to come back in a few weeks. And they're going to say that doctor had no idea what they were doing. They didn't fix my toenail. And I know they said I have high blood pressure, but I feel fine. So I don't even need that medicine. So our patients don't have that experience. They know physiology of why their disease process is occurring. They know what their treatment options are and why we as a team, me and the patient, have come to the decision to choose that specific treatment for that individual. It's not a one bucket catch all. And then they also don't get a chance to say, hey, doc, is this blood pressure medicine going to give me any side effects? And I'll say, oh, well, there's a small chance it can give you a chronic dry cough. So that patient who did take that lisinopril then shows up at the pulmonologist 6 months
Oh,
later with a chronic dry cough that was caused from the blood pressure medicine that could have just been easily switched had they known. So there's all those different factors that would not occur in our DPC practice because of the amount of time that I can spend with my patients. And they also know that they're going to follow up with me in 2 weeks and have to check their blood pressure at home. So they're much more likely to be compliant with the treatment that we choose.
yeah, I bet those just few extra minutes you have to spend with a patient can save them so much time and really change their outcomes.
Absolutely.
So, last question, what kind of misconceptions do you encounter about DPC?
So the biggest misconception, I'll do one from the patient perspective and then from other providers' perspective. So from other providers, when I go to the family medicine conference, I hear a lot, well, you're not helping access, you're actually taking it away because
Mm.
seeing so many less patients. My patient panel is 700 versus 7,000 in a traditional insurance practice. And my typical answer to that question is my choosing this style of practice does not create an access problem. The access problem already exists because we have a shortage of primary care doctors in the United States by about 40% of what we actually need. We actually have more specialists in the United States than we do primary care providers. Um,
Wow.
so there's a huge disconnect there. And because of that, the insurance company and the hospital that owns those primary care practices says you have to carry 7,000 patients and you also have to supervise 7 NPs or PAs and their 5 to 7,000 patient panel. And so, in that model, the patient is set up for failure, and so is the physician. So, in order to try to change that, we need to create more residency spots. Has nothing to do with DPC. And I don't know if most people are aware, but there are medical school graduates every year who do not match to residency spots. So they spent 4 years in medical school, 4 years in undergrad, sometimes more with a master's program, and they do not have the training to actually be able to practice as a physician. They don't have a spot. So that is where the issue lies with truly with our access, and that needs to be fixed by our government creating more residency spots because they are government funded. So that's the biggest misconception from primary care doctors. And then the biggest misconception from patients, we hear this at least once a week on the phone when somebody calls, is why would I pay for your practice when I'm paying for my insurance? And I think that question has easily been answered by everything we just talked about.
Yes.
Typically saves people money when they have DPCs because they're not dipping in to that deductible that they have to meet every year. And then they're not having costs go up because of their overutilization. And then, they just get that better access and better care. And so, I think in the US, we have no problem spending $12 on a Starbucks. But when it comes to having to pay for our healthcare, we have a hard time doing it. And unfortunately, we don't live in a country where healthcare is considered part of what we deserve access to. We have to pay for it. So I think utilizing that mindset of you are not given health, you have to work at it. And so utilizing money to pay for good healthcare, actually, the data shows us worldwide that someone's access to quality healthcare is going to lengthen their life. So I think that is something that patients don't understand until they walk in the door. We do offer at our practice meet and greets. So we're happy to see
Oh,
patients
nice.
come in. They get 30 minutes, sit down with me or Dr. Clem, and learn about the practice and talk about what's going on with them to see if we're a good fit. So I really encourage people who are struggling with their health to find a DPC that can help them.
Fabulous. Well, Dr. Farley, thank you so much for all of the information, for your passion, and doing your part to hopefully improve healthcare.
Absolutely, Amanda. It was great talking to you today.